All right. Well, if your brain was not firing on all cylinders this Saturday morning before those presentations, I bet it probably got warmed up with those. Again, one more thank you to our trainees who just presented on demyelinating encephalitis, convulsive syncope, and diabetic stridopathy. Thank you again. Next up, I have the honor of introducing Dr. Amish Dave. He is joining us for our first plenary today. He's joining us as the Associate Program Director of the Virginia Mason Rheumatology Fellowship and the Director of CME at Virginia Mason. He's a board member of the Coalition of State Rheumatology Organizations. He's also on WISMA, ACP Washington Executive Council, the Washington Rheumatology Association, Indian American Community Services, and the ABIM Rheumatology Specialty Council. He's also the incoming president of King County Medical Society. So we'll have you take it away, Dr. Dave, and he's presenting on Rheumatology Potpourri this morning.
Thanks so much, Delaney. And then I just want to make sure you guys can see my title slide, if that's
Yep,
okay.
we
And
certainly
let's see,
can.
we go to slideshow. I'm sorry, I'm not used to this Google version. I'm a PowerPoint person, so let's see if I do this and
Go to
hopefully you
the
can see my full slide. Is that okay? And I can just flip between slides.
Or
go to
in the
the
top
right
right,
side. Yeah.
there's that slideshow up in the top right.
Oh, you're the best. Okay, let's start that. Perfect. All right. Thank you so much. That's what I was looking for. All right. Well, thanks so much for welcoming me to speak today. I have a lot of ground to cover, so I'm going to try to do my best to cover a little bit of rheumatology potpourri and topics that I think Delaney and I thought might be helpful to cover today. And so I have a lot of disclosures, and Delaney covered some of those. I'm a board certified rheumatologist at Virginia Mason Medical Center and our director of continuing medical education at Virginia Mason. I'm the associate program director for our new rheumatology fellowship, which I'll speak a little bit about at the end of today's presentation. I'm a board member of the American Board of Internal Medicine for Rheumatology, as well as the Great West Board of the Arthritis Foundation, and on the Board of Trustees for CSRO, the Washington Rheumatology Alliance, an AMA delegate for Washington State through WISMA, and a former president of Northwest Rheumatism Symposium. And the information I present today will not be information or slides from any of these organizations. And so we're going to cover a bunch of different things today. RA updates, a little bit update on CAR T cell therapy, and then talk a little bit about dermatomyositis and IgG4 disease, followed by giant cellularitis, and then just a little bit about, how are we doing in rheumatology in Washington State? What are our wait times looking like? And then a gratuitous plug for our new rheumatology fellowship at Virginia Mason. So briefly, as those of you guys know, we have classification criteria for a lot of different conditions in rheumatology, and classification criteria are meant for research purposes. They're specific, but they're not always super sensitive, and they're meant to find homogeneous cohorts of patients to enter into research studies. So the 2010 ACR and European League Against Rheumatism criteria for classification of RA have not changed or been updated since then. We're still looking for signs of synovitis in small and medium joints in individuals, looking for symmetry, ideally for classification of rheumatoid arthritis, and still looking for signs of positive rheumatoid factor or CCP antibodies in many patients with seropositive rheumatoid arthritis, taking into account elevated inflammatory markers and the duration of synovitis as well. What has changed since 2010 is more information about the biogenetics of rheumatoid arthritis. We know that there's a lot of risk factors that increase the risk of a patient developing rheumatoid arthritis, including a patient's genetics, like family history of RA, but also smoking being the biggest modifiable environmental risk factor. And what we're learning about a lot more is there seems to be a lot of modification through citrullinization of proteins. Remember, humans typically do not have enzymes that convert, in most individuals, arginine to citrulline peptides. When citrullination occurs, it's often because of aberrancies in genetics or some environmental toxins. We've often posited smoking, and there's been a lot of questions about gingivitis, particularly Porphyromonas gingivitis, a type of bacteria in the mouth associated with gum disease that might be associated with the citrullinization pathways in patients with CCP antibodies or rheumatoid arthritis. And what we're learning is all of these different factors might lead to, including autoimmune autoantibody production ultimately lead to the body having immune activation in aberrant ways, a loss of tolerance for normal proteins, the development of these autoantibodies against specific targets in people with RA, and then a whole host of different types of inflammatory cascades that occur involving things like T cells, B cells, and fibroblasts. And ultimately, that leads to destruction of healthy tissue, including cartilage and bone. Um, and buildup of fibroblast populations that leads to destruction of the normal joint matrix, as well as activation of osteoclasts that lead to secondary osteoporosis and osteopenia in our patients with RA. And so there's a lot of different areas in which you can intervene to try to stop, hopefully, RA pathogenesis, including like focusing on environmental factors like reducing smoking prevalence in patients to potentially intervening earlier in our patients. And work that's being done right now, including at the Allen Institute, is really focused on trying to understand what's going on in patients with anti-CCP antibodies, including first-degree family members with CCP. This is work that's also being done heavily in VA institutions. Like, I'm not sure now with research cuts, but historically the VA has been a huge focus on RA research, including people with anti-CCP, as well as the Benaroya Research Institute at Virginia Mason. But a lot of work being done at the Allen Institute looking at monocytes in particular that are producing lots of inflammatory cytokines and trying to understand how these monocytes become macrophages that invade the tissues of patients with rheumatoid arthritis. And recently, there's been more identification of new biomarkers. It's 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 from the Allen Institute in these monocytes that might ultimately be things that we're tracking over time. A little bit too early to say, but this was one of the more seminal pieces of work that's occurred in RA in the last year, and it's coming out of the Allen Institute. So, like I said, RA is a disease with a lot of different manifestations, not just within the joints and the cartilage, but also involves systemic inflammation. So, we've long known that people with our autoimmune diseases have higher rates of depression, anxiety, mental health issues, and we worry about everything from heart, lung, and kidney disease, as well as eye disease in our patients. Not to mention all the comorbidities that occur from steroids and uncontrolled inflammation in the body, including obesity and osteoporosis, as well as a secondary fibromyalgia in many patients with RA. And so, treatment of a lot of these and trying to prevent a lot of these manifestations of RA has really focused on antibodies. And what we're seeing really is that today in 2025, we have more treatments for RA than ever before. And one of the challenges for the future is trying to understand what personalizing RA treatment to understand which cytokines or which molecules might be more involved in patients. So what I didn't present today is the fact that there's a whole bunch of different per se genome analyses or personalized therapy tests that are out there. They're not FDA validated, but we're seeing them proliferate, and some of them are being used at places like Swedish to identify which patients they think might be less likely to respond to things like TNF inhibitors, and which patients might then respond better to other therapies for RA, like JAK inhibitors or co-stimulatory blockade in treatments such as abatacept. So more to come on that. And because those aren't validated yet and they're just initially being introduced, I didn't want to identify any particular brand name, but you probably will start hearing about them. What you also probably started hearing about is biosimilars, because we're actually in what some people call the era of biosimilars. So biosimilar is a biologic medicine that's a close copy of, not exactly an identical version of an initial biologic medicine. And so again, these are also targeting very specific proteins in the immune system to try to shut down a whole pathway of inflammation and disease. And it was really hoped that biosimilars would reduce the costs of biologic therapies. And more or less, even though we're seeing slight reductions in costs for maybe some large insurance companies, we aren't really seeing that for patients themselves. So biosimilars also need to be tested and evaluated by the FDA and they're only approved if they're shown, at least in some small studies, to be as safe as helpful as the original biologic. And they essentially are felt to have the same risks and benefits. And slowly over time, we're seeing more biologics, or I'm sorry, biosimilars released over time. So we're now up to at least 3 to 5 different adalimumab biosimilars. The challenge is that the companies have become very smart at essentially playing the game. So AbbVie now makes its own adalimumab biosimilar of Humira, but also released another version of Humira a couple of years ago, to citrate formulation of Humira, or citrate-free formulation that supposedly stings less when people inject it. And they also have the original Humira, and they've started competitively pricing all 3 versions of them as, say, biosimilars, and as well as other companies making other adalimumab biosimilars. What we've also seen in 2025 was the release of the first tocilizumab biosimilar, and that's interesting also because as Tyenne and Tofidence is out there too, but I haven't really been seeing it used. And then after Tyenne was released, actually it was approved in 2024, but released in 2025. There's a newer one that's just been approved, Avtosma, and we're waiting to see if there's any reduction in cost in tocilizumab. So more of these biosimilars will come out, not just for rheumatology indications, but as you can see at the bottom of this chart, Tysabri natalizumab has a new biosimilar that's coming out for MS, multiple sclerosis treatment as well. And the issues of biosimilars is also just even more important because what we're seeing is that even though insurance companies are battling, and they would argue that they're trying to get the best deal with the manufacturers of these biosimilars, they might be getting a cut, but there's no actual benefit to most private practice rheumatologists or even hospitals for the biosimilars. So what we're finding is that physicians who are administering biosimilars are often being reimbursed less than what it costs to purchase it, and certainly less than what it costs to administer it. And so what we've been seeing in 2024 and accelerating in 2025 is that entire hospitals are shutting down in Washington State and nationally, are shutting down their infusion centers. We're seeing the proliferation of private practice infusion centers across Western Washington. I think we're up to like 30 now, from everywhere from Bellingham down to Lacey. And more of them are going to pop up across Washington because it's just not affordable for hospitals and many clinics to administer biosimilars. So I'm on the board of a group called CSRO, and we have been advocating on behalf of this issue of underwater biosimilar and to try to increase reimbursement for biosimilars. And this is a topic near and dear to my heart. What we're also seeing for RA is that aside from just medications to treat RA, there's newer ideas that are coming out. So I'm not going to read this entire story for you guys, but this is a beautiful. I'm getting more into narrative medicine, and one of my goals in the next year is to be able to help my patients to write down their experiences as a way to process their experiences, and also give myself and our fellows an opportunity to write down our experiences in rheumatoid arthritis more often. But this is a beautiful article in NPR about a nerve stimulator for patients with rheumatoid arthritis. So the story essentially is that this is a woman who's suffered and really not felt like she could really leave her house because of swollen joints. Her children couldn't hug her. Her husband couldn't hold her hand. And she tried a whole bunch of different medications, but ultimately went to surgery and got embedded with a lima bean sized device near her vagal nerve that essentially within a few weeks to months helped to reduce and eventually stop most of her pain. And this is something that patients are definitely hearing more about. It is a vagal nerve stimulator. And at its basics, by inserting this device and planting it, a vagal nerve stimulator, it's sending a signal to the hypothalamus, which is which is a part of the brain that we've known for a long time regulates body functions and also interacts with the immune system. The hypothalamus is then responding to to these stimuli by sending further signals back down the vagal nerve to the spleen, and the spleen is actually incredibly important for production of cytokines. So the signals now coming from the hypothalamus are now slowing down the production of cytokines, which are then reducing inflammation in the body and reducing inflammation within our joints. And so this is a therapy that is still kind of in its nascency, still being evaluated. There's trials that are starting up right now at OHSU, and UW is the only site that's doing this right now. But more to come. What we're seeing is that insurance companies are creating more barriers through prior authorization limitations. And so patients will often have to fail multiple therapies. And it's not yet clear how many therapies people might need to fail for an insurance company to approve a vagal nerve stimulator. But if the cost of a vagal nerve stimulator surgery is, say, 50K, and it's a one-time deal, and the cost of a biologic like Humira or adalimumab is now about 70 to $80,000 per year, you can see how an argument could be made for many patients to be able to proceed with vagal nerve stimulation in the future. Lupus. So lupus is a disease. I was teaching about it for 2 hours yesterday to our Trios residents in Eastern Washington, and it's a disease that I was asking them what do they think is the actual prevalence of lupus in the population, and many of the residents, every time I ask this every single year, and people will say something like 10%, 15% of the population have lupus, and maybe that's not, and I think we're never shocked by that. I'm a little bit shocked when people think 15% of the population has lupus, but I think the number of people in our population who think that they have lupus always seems to be increasing, and it might not. It might be partly because there's such recognizable individuals out there like Selena Gomez speaking about their experiences with lupus, and because lupus is such a heterogeneous disease. Indeed, lupus is one of those diseases that we love talking about and thinking about in rheumatology clinic, and our fellows love talking about because it can present in just protean manifestations from the classic butterfly rash on the malar regions that spares the nasolabial fold to inflammation of really any part of the body, and certainly with constitutional symptoms and synovitis as well. And the 2019 ACR criteria for lupus have not been updated yet, and we're still waiting for an update. One of the main reasons why we're waiting for an update is because these were, quote, validated in lupus samples around the world, but 95% of participants that they validated on were Caucasian women. And we know that um, the most severe presentations of lupus tend to occur in Black women as well as women of color, including Asian, Latina, and Native American women. And so there's a lot of questions about the validity in people of color for lupus. Indeed, about 90% of people with lupus are women, about 10% or so are men. And the ACR classification criteria are really only meant for research purposes. Again, they're meant for entry into clinical trials. And so probably 2/3 of people with systemic lupus do not meet 2019 ACR-EULAR classification criteria for lupus, the more that we look at it. But this is still what patients are looking at online, and this is what clinicians are looking at online. So really want to emphasize that even though these criteria are out there for research purposes, and even though they can be useful to see what certain manifestations of lupus are, they're not the end all be all. And ultimately, lupus should ultimately be diagnosed by a rheumatologist. And that also kind of goes into the question of ANAs because um, ANA, it's amazing how many people check in ANA, and we get about 150 to 200 referrals to our rheumatology practice at Virginia Mason every week, and easily about 40 to 50% of the time, there's just a positive ANA result, and there might not show up with a titer, and we might not even get an explanation for why an ANA would be tested. So I have to remind people that ABIM, ABFM both have a Choose Wisely campaign, and one of those things, the factors in the Choose Wisely is really thinking about why and when you should order an ANA. So ANA again are these anti-nuclear antibody tests, where really your body is forming antibodies against something in your body, and it's a non-specific test. And it's really important to recognize that a positive ANA in and of itself does not automatically indicate a specific disease, as many healthy people can also have a positive ANA. A positive ANA test should be followed by a discussion with a doctor about whether further tests, what we call subserologies or ENA tests, extractable nuclear antigens, are needed based on the symptoms and clinical picture. And ordering the subserologies, like just ordering a double-stranded DNA or a CL70 without a positive ANA and without a strong clinical picture of a clinical disease, can often lead to unnecessary investigations, iatrogenic harm, and wasted resources. And I'll say that overwhelmingly, the positive ANA referrals that we're getting there are definitely physicians who are ordering them, but overwhelmingly they're APPs and naturopaths who just might not have the education and the knowledge about when and how to interpret ANA tests. And I think another thing that we just want to emphasize is the growing role of anti-DFS70 antibodies. So I used to say, like, when you get the pattern on an ANA, it's not all that helpful. And, the few exceptions are when maybe I saw a centromere antibody where it would raise some questions about, like, could there be any signs of limited systemic sclerosis or CREST in this patient? Is there something I'm missing? But for the most part, whether someone had homogeneous or speckled or nucleolar, we kind of ignore it. It wasn't as useful as, say, the titer or the clinical picture and the physical exam on the patient. But more and more, we're realizing that many people are getting further testing for anti-DFS dense fine speckled pattern antibodies, especially if they have a speckled pattern ANA. And so DFS70 positive finding on ANA tests really actually strongly suggests that the person is healthy and they do not have an autoimmune disease. So it's a finding that's a positive finding that someone does not have a systemic autoimmune rheumatic disease. So when we just see a referral for positive ANA with a speckled pattern, we might ask a primary care doctor to check a DFS70 because really, if someone has fibromyalgia or chronic fatigue syndrome and a speckled pattern that turns out to be DFS70, we would really rather not see them because no further workup would be necessary. And then moving on a little bit to our next topic. So, talking about CAR T cell therapy, which is certainly being looked at with lupus. So, for a long time, and even right now, the basic treatment for systemic diseases, including lupus and systemic sclerosis and myositis, polymyositis or dermatomyositis, involves long-term immunosuppression with use of steroids for flares. And ultimately, obviously there's a lot of comorbidities, including risks of infections and steroid-related side effects with immunosuppressive therapy. And so there's long been hope about what about a cure or what about a treatment? And so what's occurring right now is that at sites across the country, and I think there's 6 sites, is my understanding, in the United States for lupus, there are clinical trials occurring for CAR T cell therapy. And CAR T cell therapy involves infusion of a CD19 chimeric antigen receptor cells into patients who are already preconditioned and immunosuppressed with either with fludarabine and cyclophosphamide. The hope is that these CAR T cells can reset aberrant autoimmunity by providing a deep depletion of B cells. And the hope is that this will lead to many years of remission. And initial studies that were done, including in Germany, evaluated 15 patients with severe lupus, including that was 8 patients, 3 with myositis, and 4 with systemic sclerosis, who just got one infusion of CAR T cells. And what they did then was follow them over time with a different reputable indices or scores for remission criteria for either lupus myositis or scleroderma over 2 years. And they also looked at safety variables. And what they found after about 15 months of following the patients, the mean duration of follow-up, I'm sorry, was 15 months for these patients. All of the patients with lupus met what were called DORIS criteria for long-term remission. All of the patients with myositis met ACR-EULAR criteria, and all of the patients with systemic sclerosis had a decrease in their long-term inflammation and long-term sclerosis findings. I mean, actually, if you look at these graphs and for individual patients and their degree of either the decrease in double-stranded DNA for lupus or the decrease in their SLEDAI score, which is a validated score for inflammation with lupus, or their CPK levels with myositis, these are some of the most profound improvements that we have ever seen in rheumatology. And immunosuppressive therapy was completely stopped in all patients, and kind of astounding with CAR T cell therapy. And so a follow-up is occurring. And so in these patients, essentially, cytokine release syndromes with intense inflammation occurred in 10 patients. And that included one patient who had like a neurotoxicity syndrome and pneumonia that led to hospitalization. That patient survived. And longer term, there are patients who had herpes simplex and herpes zoster and a case of cellulitis and upper respiratory tract infection risk. But in general, for all three of these diseases, again, very small populations, the initial study that was done was found to be extremely safe and efficacious, especially considering these were people who got fludarabine and cyclophosphamide as well. And so the site in Seattle where they're doing CAR T cell therapy is Swedish. Dr. Phil Meese, and then from rheumatology, and Dr. Swati Namburi in hematology are conducting these studies. I will say that we have been referring many patients to Swedish for entry into clinical trials for lupus, and also they're doing scleroderma now. Entry criteria are super stringent. There's age cutoffs that all seem to vary. There's a lot of restrictions on whether someone's had thromboembolism history, on whether they have particular cytopenias. So it's hard to figure out exactly which patients they want, nor do they actually publish these online. And so we've definitely been referring extremely ill patients with scleroderma as well as lupus to them. And I think I've had one patient who's been accepted so far out of like 20 that we've referred. Many more patients have interest in joining these CAR T cell therapies, and ultimately, the big challenge is going to be the cost. So these are easily going to be over $300,000-$400,000 for, say, one treatment of CAR T cell therapy. And I think it's going to be a question of, like ultimately, if you get that one treatment and you're remission free for many, many years, and don't have to spend a lot of money on a particular DMARD cocktail of medications, will it be worth it? And will insurance companies sign on for it? It's going to be also be a huge issue for Medicare and Medicaid, especially in an era of major cuts coming. So switching then briefly to dermatomyositis. So dermatomyositis is a disease for which, for a long time, rheumatologists have mainly used steroids, and then have tried for initial induction therapy for reducing inflammation. And then we'll use a whole bunch of different medications from azathioprine, methotrexate, Cellcept, rituximab, or IVIG or cyclophosphamide as steroid-sparing DMARD medications. In recent years, there's been more studies being done on IVIG, and finally, IVIG seems to be like the first medication that has FDA approval for dermatomyositis, which is a godsend and especially super helpful because IVIG is something that can be monitored. It can be done in the hospital or the outpatient setting. And certainly we know IVIG is super helpful when people have severe manifestations of dermatomyositis, including difficulties with dysphagia, with skeletal muscle involvement in the esophagus. And so that's been actually very helpful. And a follow-up study called ProDerm that's being led by Dr. Rohit Agarwal at the University of Pittsburgh. This is was recently published this year, which is a randomized placebo-controlled trial looking at the efficacy of IVIG on non-muscle and non-skin systemic complications of myositis, where patients are essentially getting Octagam, 2 grams per kilogram, every 4 weeks versus placebo. And ultimately, they found that in every way possible, patients who received IVIG therapy saw substantial benefits, both in their mean global their VAS scores. So these are validated scores for inflammation in patients with dermatomyositis, and they saw improvements that were statistically significant in pulmonary, skeletal, just global constitutional affect, as well as GI complaints, and that was certainly not seen with placebo. And so these are going to continue to help us. It's nice to have this data so we can continue to get IVIG approved. It's obviously much easier when people are on traditional Medicare Part B with a supplemental to get it approved. But now these data really help us with other manifestations of dermatomyositis to get IVIG approved. Briefly on IgG4 disease, so this is also one of those diseases like lupus with protein manifestations. It's a really rare chronic inflammatory condition that involves inflammation of a lot of different glands through deposition of IgG4 levels. So often patients, but not always, will have high serum levels of IgG4 antibody. And over time, as these antibodies build up, People can get swelling in their parotid glands and their salivary glands. They can get lung inflammation. They can have recurrent episodes of pancreatitis or retroperitoneal fibrosis, as well as just a whole bunch of other manifestations that occur, including enlarged lymph nodes throughout the body. And on biopsy, you'll see tissue with a lot of IgG4 infiltration, what's called a story-form fibrosis, where it almost looks like apartment building floors of fibrosis that are being seen in tissue, and destruction of blood vessels through thrombosis or phlebitis. This is also, we've known for a long time that IgG4 really involves a lot of T cells, like regulatory T cells that are being invaded. And for a long time, we've known that if we can get patients approved for rituximab by depleting B cells and controlling T cell activity, then we really are able to reduce or even reverse a lot of the damage that's seen in IgG4 disease. But rituximab has never been FDA approved for IgG4. Um, this year, we finally see, or end of last year and now released this year, we finally see approval of a new monoclonal antibody that is probably the most difficult monoclonal antibody to pronounce to date, in ebilizumab, which, pardon me, but I'll call it Uplizna, the brand name, just because it's hard to say in ebilizumab like multiple times straight. But this biologic monoclonal antibody targets and depletes CD19 positive B cells. And based on a phase 3 double-blinded randomized placebo-controlled trial where patients got Uplizna versus placebo for 52 weeks, they essentially got two infusions 2 weeks apart, similar to rituximab initially, and then they also got a third infusion at week 26. What they ultimately, and then they followed, patients got identical initial glucocorticoid tapers, and they followed whether people had flares as a primary endpoint over time, and also whether people were able to be flare-free and glucocorticoid-free as secondary endpoints. What they found was that ultimately with Uplizna, you can see on this graph compared to placebo, people really stayed disease flare free. And that was kind of an astounding improvement, similar to what has been seen previously in data that's come out in rituximab. There is to date no clinical trial, or at least we don't know of any clinical trial coming out about Uplizna versus rituximab. It's probably not in the interest of either manufacturer to do that. But what we do know is that we will hopefully have this as an FDA-approved medication um, as it's being rolled out right now for our patients with severe manifestations of IgG4 to be on. And then I'll also just say that there really wasn't much difference, at least statistical difference, between placebo versus inebilizumab for serious adverse event occurrence. And so yeah, so it's a dosing very similar to rituximab, and I think contraindications include, similar to all of our rheumatology biologics, any active Hep B or active TB um, presentation or presence, and then also any prior adverse drug reaction to the medication. So briefly about giant cellularitis also. So this is a disease that we actually see a lot in Seattle. I swear I see so much more of this than I ever did at Stanford, University of Chicago, or Harvard, just because we have such a large Northern European and Scandinavian population. But GCA and PMR are cousins with basically the same genetic mutations that are noted. And this is a large vessel vasculitis, much more common in women compared to men, but seen in both. And it almost never occurs under the age of 50. I'll say that like in several years now, like 15 years of doing rheumatology, I've probably only seen like 4 or 5 patients below 50 who've had polymyalgia, and I have not yet seen anyone with giant cell arteritis below the age of 50. The peak incidence of GCA is between 70 to 80, and it's really important to recognize that it can involve any of the branches of the aorta, including the temporal arteries or the coronary arteries as well. And this is a pan-arteritis that involves inflammation. On biopsy, you'll see inflammation all across all layers of the blood vessel wall with a dense inflammatory infiltrate in the center. So in the last few years, we've had approval of tocilizumab, which is an IL-6 therapy, and this is really based on GIACTA trial run by John Stone at Massachusetts General. GIACTA is one of those seminal studies of the last 20 years in internal medicine, which was a double-blind placebo-controlled trial of tocilizumab injection, 162 milligrams versus placebo, and really found to be astoundingly effective at reducing the rate of flares, getting people off of steroids, and staying off of steroids. And then in the last couple of years, we've faced a lot of challenges with getting tocilizumab for our patients. Um, One of them is determining which formulation might be approved for patients, whether an IV or injectable formulation is approved for our patients, and then ultimately determining like how long do you keep people on tocilizumab. So this initially there was a hope that after 1 year of therapy you'd be able to get people off of it. Then they found that still a lot of people flared, and so then we've talked about 2 years of staying on tocilizumab and then trying to stop it. And the data is still lacking. So we're waiting to see whether tocilizumab is a lifelong therapy versus whether it's something that could be stopped. And then after tocilizumab came out for giant cell arteritis, sarilumab, data on sarilumab came out for polymyalgia rheumatica. So this is another IL-6 inhibitor and another phase 3 multicenter double-blind placebo-controlled trial in patients with polymyalgia rheumatica. It was found in 118 patients who were studied that those patients in the wing that received tocilizumab had far less symptoms had far more sustained remission at 52 weeks compared to placebo, less need for steroids, and ultimately, the safety signal actually looked pretty good, aside from maybe some mild neutropenia and some arthralgias and some diarrhea. Most people with sarilumab actually did very well. The challenge, of course, is that now we have two different IL-6 inhibitors. Sarilumab to date is only an injectable; it's not an infusion. Tocilizumab is both an infusion and injectable, but sarilumab, because most people with polymyalgia rheumatica are Medicare age, sarilumab has never been released as an infusion that will be covered by Part B, and so it is still extremely expensive. And many of our patients are always terrified about any changes in insurance if they have polymyalgia rheumatica, because any changes to Medicare that or things that drive up the cost of their insurance or their copay will dramatically make it more expensive for them to be able to afford sarilumab and stay on it. Um, and then another thing came out this year. So another medication for giant cell arteritis is Rinvoq or upadacitinib, which is a JAK1 inhibitor that had already been approved for rheumatoid arthritis, plaque psoriasis, and psoriatic arthritis. And then another study came out this year and that published in the New England Journal of Medicine after a phase 3 trial, a placebo-controlled trial, that showed that 15 milligrams of upadacitinib, but not the lower dose of 7.5 that's sometimes used in RA, was actually found to lead to a sustained remission when given with a 26-week glucocorticoid taper. So we don't yet have back-to-back clinical trials of tocilizumab versus upadacitinib for giant psoriasis to see which is more effective, but that is almost certainly one of the biggest debates in rheumatology and more to come. But it's nice to actually have a pill to treat giant psoriasis instead of an infusion. The challenge will be that insurance companies will determine which medication a patient will get based on where they get the best deal with manufacturers. And so for most of our patients, though, it's nice to have something that's a pill a day. Certainly, if they get infected, you can stop it and help people to have restitution and be able to fight off an infection faster with something like upadacitinib. And so then very briefly, and I'm sorry for running a little bit over, we at Virginia Mason, like all rheumatologists in this region, recognize that we actually have one of the most underserved parts of the country per the 2015 ACR and Allied Rheumatology Health ARHP practice survey, workforce survey. So we actually have the highest number of patients to number of rheumatologists. There's only probably about 60 rheumatologists in Washington state, and many of them either do research or only part-time. And so it's extremely challenging to practice rheumatology in the state. Many people like me have, I have 4 different state medical licenses just to be able to cover televisits. And we really have to then rely very carefully and closely with our primary care colleagues to help us with everything from writing infusions in other states to helping to manage a patient until they can be seen. We did a study with Lauren Powell and Mariah Moore, two of our wonderful prior Virginia Mason residents a long time ago, looking at consultation wait times in rheumatology. So this is dated. This is probably like 8 years old that we published this, and this was based on telephone calls. And we found that on average in practices is about 60 days that practices would report that it took a patient that a patient could get a visit. Obviously, most patients can't just pick the one day or one time that a rheumatology office says they can come in. So we actually know that wait times are probably much longer than what was reported by these practices. And so what we've tried to do over time within Virginia Mason for our Department of Primary Care is we came up with a service agreement on what we will see and what primary care will take care of. And so I'm happy to share this with anyone who's interested in seeing this. And our practice typically will not see second opinions for fibromyalgia, OA, osteoporosis, hypermobility, chronic regional pain syndrome, simple gout, or CPPD. We definitely don't want to take care of autoimmune thyroid disease or MS. And we try really hard to get people to UW dermatology to take care of both pemphigoid and pemphigus vulgaris. We've also kind of worked within our Cerner system, and we're moving to Epic next year, but on developing with our primary care colleagues a list of what type of labs and what type of imaging might be helpful. And always happy to talk about this with anyone who's interested. We've slowly expanded the number of our rheumatologists, and we actually are very fortunate that we now have two pharmacists within rheumatology who are both helping us, as well as two nurses who've been helping us with biologic injection training, teaching, and following up on everything about like what to do with holding a biologic during surgery to what to do if someone has an infection. And we're very grateful that we were able to get ACGMA approval for a 2-year fellowship that just started this year. And we just finished interviewing 41 candidates for 2 spots for our fellowship next year. So next year we'll have 4 fellows. Yay. And I've been working a lot with our Washington Rheumatology Alliance to make sure that all the fellows at UW, Seattle Children's, and Virginia Mason get funding to be able to attend conferences like our American College of Rheumatology conferences because the conferences are crazy expensive. We've also, just a quick shout out and thank you to UW, because we actually, as starting up a new fellowship is actually extremely daunting. And UW actually welcomed us into the didactics pool. So fellows from Seattle Children's, UW, and Virginia Mason all do their didactics together on Tuesday morning. Actually, I don't know any other state that has something similar. So we actually have incredible collaboration with the UW on our didactics. And so happy to always talk more about this, but we've also been working with radiology and pathology and pulmonary and a lot of other services at Virginia Mason to make sure our fellows are having amazing training. And we work with UW Harborview Clinic on MSK ultrasound didactics for our fellows. These are two fellows. They're wonderful, and you'll probably see them. And actually creating a new fellowship, I'm happy to talk about that with anybody, but it's actually taken our wait times down from over 140 days to 63 days. I know it's still high, but like, trust me, over 150 days to 63 days feels phenomenal. And certainly we are able to sneak in more urgent, like sick people with John psoriasis and ANCA vasculitis and pulmonary renal syndromes in faster. I've also been advocating for us to hire more rheumatologists at other sites. And so we now have two rheumatologists in Silverdale. A third one from Detroit will be joining us next year. And we're tracking how this works across the system. So I'll stop there just 4 minutes late.
Thank you so much, Amish. That was just a fantastic and really uplifting rheumatology presentation. Just so many effective therapies in the pipeline and already working on your patients, as you showed. We do have some questions in our Q&A chat, so I'm going to go through those with you briefly. First one, we have an ANA reflexive panel that automatically sends sub-serologies. It's basically impossible to turn them off. Can you comment on what to do with low titer ANA and negative sub-serologies?
Yeah, so I think what's important to recognize is what the University of Washington and VM have been doing is a two-tiered ANA. So the first ANA that occurs is the ANA multiplex, which is what similar to what LabCorp does. A multiplex is not, it's very sensitive, it's not very specific. And what it's basically doing is it's a machine test to look for any antibodies. It often errs on a positive result. And so the follow-up should be an ANA by immunofluorescence, where lab technicians are actually staining and looking at immunofluorescence of blood and detecting the antibodies and giving you a titer. With Virginia Mason and UW, they do those somewhat very similar pathways, and we worked a lot with Mark Winter at the UW to standardize our process. So we check if you get a positive ANA by immunofluorescence, there's 7 different ENA antibodies that are checked. Generally speaking, a lot of people in the population will have a slight titer of an ENA antibody, just especially if they have a first degree family member with an autoimmune disease. RNP is the most common false positive or low titer ENA antibody. So, generally speaking, for most ENAs, if they're below 3, I look at those as negative. I don't look at those as positive unless there's some flaming, like clear thing that like a malar rash that's so obvious and horrible synovitis. If it's just slightly high, I don't look at that as positive. Double-stranded DNA, a cutoff varies by labs, but it's usually 9 to 10. And if it's much higher than 10, then I look at that as positive. When it's just like 10 or 11, it's just slightly high, and we don't necessarily panic about that. It could just be from UVB light exposure over time. Um,
Great. The second one is there a specific reason why women are more affected by these autoimmune diseases than men?
that
Any
is like a
insights on the mechanism?
That is like a multi-million dollar question, multi-billion dollar question. I would say, like, I was just talking about this yesterday with our fellows, but Behçet's is the only disease found to be more aggressive in men compared to women. Almost everything women have worse outcomes. And there does seem to be, I mean, there is some question of a hormonal component of this. So, where a lot of women with lupus will go into remission after menopause, for example. And so we try to like wean people, or I try to wean people off of hydroxychloroquine after menopause. It doesn't always work, and then we just go right back on it. And I apologize, we put them on prednisone and other DMARDs, but for the most part, I mean, we're waiting to find out what it is. Um,
Great. One physician states, my partners and I have a number of older physicians with PMR who take Pred 2.5 or 5 milligrams chronically because of flares. Some of these therapies have been carried over for decades and people don't want to wean off of them. Should we refer them to Rheum to consider IL-6 blockade?
Probably not. I mean, to be honest, most people who are on long-term prednisone for years just have adrenal insufficiency, and being put on IL-6 blocker will just immunosuppress them, but they won't really be able to get off of their prednisone. And a lot of times, I mean, we see this all the time when you're on steroids for a long time. Um, it's like Hamana from heaven, especially like it really like I feel like it replaces the estrogen, it lubricates your joints, so you just feel great. So they're just gonna feel miserable if you try to taper them off of prednisone. Every so often we have people with just god awful osteoporosis and multiple fractures, and we really try to taper them like gingerly and extremely slowly, by like 0.25 or zero point 0.5 every few weeks and stuff. And I have a few who've really succeeded at doing that, but for the most part, no.
Great. Next question from one of our POCUS teachers, Dr. Shepard. Any benefit to temporal artery ultrasound instead of biopsy in diagnosis of temporal arteritis?
Yeah, I mean, this is a huge question internationally. We and there's a lot of disagreement even within our group. I mean, I think in general for most patients, when you suspect John psoriasis, you're still going to start them on high dose steroids. If you can get them in for an ultrasound at a reputable site with training to do this, like for example, I know UW and VM both have protocols, a lot of training amongst the radiologists and their ultrasonographers on looking for halo signs and other signs of inflammation, then it's worthwhile to try to get it. I will say that we still struggle with a lot of people with questionable borderline reports, and then we're still sending them for biopsy. But if the story is so clear for GCA and you can get an ultrasound, you can avoid a biopsy, people will like that. I would say the other problem is insurance will often not look at an ultrasound as a positive enough result, especially if they're not on Medicare and you can't just get an infusion approved automatically through Part B. So for people under 65, I'm still sending them for biopsies. And so when in doubt, touch base with your rheumatologist. We have feelings.
All right, last question. Does having a rheumatology fellowship open up that practice to patients who have PCPs outside of VM?
Oh yeah, absolutely. I mean, I think VM, unfortunately, Swedish, my understanding is, and I'm looking at referrals this week, Swedish and maybe UW have closed their practices to outside providers because they're so backlogged. We are still very happy to be able to take people. We're just becoming much nitpickier on what we'll accept, and we have a lot of questions.
Great. Thank you so much again, Amish. Really appreciate your time today.